burden, how much this affect the part of the world. And we will the very important part of this presentation is different etiologies, and then we will discuss about the assessment and management at presentation. We will talk about the general support of acute liver failure, and then as acute liver failure also affect other organ of the body. So we will discuss the organ specific management. So at the end, we will discuss the definite treatment of the acute liver failure, which is known as a liver transplant. So starting from the definition, by definition, acute liver failure is a highly specific and a rare syndrome. It is characterized by just It is characterized by acute derangement of the liver function without underlying chronic liver disease. So it means somebody is developed the jaundice, coagulopathy with raised serum aminotransferases, along with the hepatic encephalopathy is known as the acute liver failure. Suppose somebody is not yet developed the acute hepatic encephalopathy or altermentation, and just having the jaundice and coagulopathy, raise transaminases, without existing previous liver disease, is known as acute liver injury. When this patient will develop the hepatic encapsulation, it is known as acute liver failure. So coming toward the subclassification, acute liver failure basically subclassified into three types. Number one is hyperacute, second acute, and third is subacute. It depends upon the development of the jaundice to development of the hepatic encephalopathy. As I told you, patient usually develop the coagulopathy, jaundice, and when he develop the altermentation, uh, suppose he develop hepatic encephalopathy within the week, it is known as a hyperacute. Suppose he develop hepatic encephalopathy from 1 week to 4 weeks, it is known as a acute liver failure. Suppose your patient is developing the hepatic encephalopathy or altermentation taking from 4 weeks to 12 weeks, it is called subacute. Why this subclassification is important? The importance of this subclassification is to know the how much chances of spontaneous recovery. Like uh, like in hyperacute, it has a very good spontaneous recovery. While in case of the acute, it has a moderate chances of the spontaneous recovery, but in case of the subacute, it has a very poor spontaneous chance of recovery. So here we can understand that somebody, he or she does not have existing liver disease and developing suddenly jaundice, coagulopathy, and hepatic encephalopathy within the week or from 1 week to 4 weeks or from 4 weeks to 12 weeks, then it is called acute liver failure. So what are the different causes of the acute liver failure? In our part of the world, virus hepatitis is the most common cause of the acute liver failure. The most common viruses are hepatitis B, D, and E. E is common in pregnancy. When pregnant women develop hepatitis E related, they develop the acute liver failure, which is a life-threatening condition. While we mostly have the patient with B and D acute hepatitis or acute hepatic liver failure. Less frequently, we have the CMV, herpes simplex virus, varicella zoster virus, and dengue hemorrhagic fever as well. Now, coming toward the drugs, which drugs causes the acute liver failure? The paracetamol overload or paracetamol toxicity is called the acute liver failure. Here, I would like to mention that the paracetamol is not a common cause of acute liver failure in Pakistan, India, or Bangladesh, or subcontinent, but it's more common in the USA and UK. We have the drug-induced acute hepatitis or acute hepatic failure like anti-tuberculosis, chemotherapeutic agent, statin, NSAIDs, phenytoin, carbamazepine. We have a toxin which is known as a mushroom poisoning. We will discuss in detail about this. We have vascular disease like Budd-Chiari syndrome is an acute emergency which may need the liver transplant. We have a rare cause of the acute liver failure which is known as hypoxic hepatitis. In pregnancies, we have the two conditions. One is the HELLP syndrome, second is fatty liver of the pregnancy, which can cause the life-threatening to the fetus as well as the mother, and we will discuss about this disease in detail. We have some other rare causes of the acute liver failure like Wilson disease and autoimmune hepatitis. So starting the burden of the disease here. Actually, we don't have the true data from the Pakistan, but we have the two countries data, which are also the part of subcontinent, like in Bangladesh and India. If you see here, the most common cause is the viral hepatitis, which causes acute hepatic failure. While when we're talking about the USA and the UK, the paracetamol is the main cause of the acute liver failure as compared to the other part of the world. Okay, so what is the importance of diagnosis and initial evaluation? Because all the patients with acute liver failure should be hospitalized and monitored frequently, preferably in the ICU. Preferably in the ICU. You must contact with the liver transplant team because definite treatment of the acute liver failure is the liver transplant. You must know the precise etiology of the acute liver failure. That will be help to further management decisions. So starting the determine etiology and specific therapy. As I told you, we will discuss about the viral hepatitis because in our part of the world, we have a common causes of hepatitis is the viral hepatitis, hepatitis B, D, and E related acute liver failure, and less frequently cytomegalovirus, simplex virus, varicella zoster virus, and the dengue hemorrhagic fever. Suppose your patient is developed the viral hepatitis E related acute liver failure, then you may start the supportive care because there is no specific viral treatment for this virus. But in case of the hepatitis B related acute liver failure, you may start nucleoside or nucleotide analogs, which is helpful in the acute liver failure as well as for prevention of post-transplant recurrence. Suppose your patient is develop the acute liver failure secondary to herpes virus or the varicella virus, then you may start the acyclovir at the rate of 5 to 10 mg per kg IV 8 hourly, and you may consider your patient for the liver transplant as well. So it was all about the viral hepatitis, the most common cause of the acute liver failure in the Pakistan, India, and Bangladesh. So second most common of the acute liver failure is the acetaminophen hepatotoxicity. Luckily, we don't have the many cases of acetaminophen poisoning. Acetaminophen basically a drug which we usually use for antipyretic as antipyretic. But whenever this drug is taken in an exceeds of 10 gram per day, it develops the uh, acute liver failure. And the evidence of this acetaminophen hepatotoxicity is very high ALT level, like more than 3,500 international units. For patient with known or suspected acetaminophen poisoning and coming to you within the 4 hours, you may give him activated charcoal before starting the N-acetylcysteine. N-acetylcysteine basically a life-saving antidote for the acetaminophen poisoning, and it should be given promptly to all the patients in which you are suspecting or you have evidence of acetaminophen poisoning. You must start this drug. So the third cause of the acute liver failure is the mushroom poisoning. All the mushrooms are not safe for the meal. Wild mushrooms are also known as the death cap. There is no blood test to confirm the poison of this toxin, but patients usually have the GI related symptoms like nausea, vomiting, diarrhea, abdominal pain, which occur within the hours to days of ingestion. Whenever you are suspecting somebody has ingested the mushroom, then you may consider administration of antibiotic that is known as the penicillin G, and you can also give the N-acetylcysteine is again an antidote for the acetaminophen, can be helpful for the mushroom poisoning. You have to inform the liver transplant team because the liver transplantation is the life-saving option for the patient who has ingested the mushroom. Drug-induced liver injury. Drug-induced liver injury. There are certain drugs that can cause the liver injury and acute liver failure. Except the acetaminophen, the rest of the drugs like anti-tuberculosis, chemotherapeutic, statin, NSAIDs, phenytoin, and carbamazepine, all they have the idiosyncratic effect on the liver and they may cause the acute liver failure. within the first month after drug initiation. So whenever you are suspecting somebody has a drug-induced liver injury, you may ask about the onset of ingestion, amount, and timing of last dose. Concerning all prescription and non-prescription drugs, you may ask about the herbs and dietary supplements. And whenever you are suspecting, you must discontinue all the medicine, especially essential medication as well. Then you may give the N-acetylcysteine to these patients as well. The uncommon causes of the acute hepatic failure is the autoimmune hepatitis. If somebody with autoimmune hepatitis, if develop acute liver failure, then these may be a severe form of the disease because 30% of them don't have the antibody. They may need the liver biopsy when you are suspecting somebody with autoimmune hepatitis develop the acute liver failure or those who have the negative autoantibodies. Patient with coagulopathy and mild hepatic encephalopathy, then you may start the corticosteroid treatment and wait for the 7 days. If the symptoms are improving, then continue this. If symptoms are not improved within the 7 days, then you may consider it for the liver transplant as well. So autoimmune hepatitis can be another cause of the acute liver failure as well. So the another uncommon cause of the acute liver failure is the Wilson disease. Wilson disease typically occur in the young patient, accompanied by abrupt onset of womb-negative hemolytic anemia with serum bilirubin level more than 20 mg per deciliter. Wilson disease is another separate topic, and it is just briefly I will tell you Wilson disease not only involves or affect the liver but also involves the brain, eyes, heart, kidney, bones, and the blood as well. Whenever you are suspecting or want to exclude the Wilson disease, you must obtain the serum ceruloplasmin, serum and urinary copper levels, select lab examination for catheter pressure ring, hepatic copper level when biopsy is feasible, and total bilirubin alkaline phosphatase ratio. Patient in whom the Wilson disease is likely to cause of acute liver failure must be considered for the liver transplant because only the liver transplant is life-saving whenever Wilson disease patient develop acute liver failure or Wilsonian crisis. Budd-Chiari syndrome. Budd-Chiari syndrome is another cause of the acute liver failure. This usually occur when suddenly hepatic vein thrombosis occur. These patients usually present with abdominal pain, ascites, striking hepatomegaly. How will you diagnose the Budd-Chiari? The Budd-Chiari usually diagnosed on the hepatic imaging and the testing to identify the hypercoagulable condition like polycythemia and malignancy. Hepatic imaging, you need the CT scan, Doppler ultrasonography, venography, MRV, and for this purpose, you have to consider the liver transplant, which is a life-saving procedure for acute Budd-Chiari syndrome. There are two conditions which can cause the acute liver failure in the pregnancy. Luckily, not all the pregnancies can develop the acute liver failure, but very small number of the women at their third trimester can develop the acute fatty liver. Pregnancy or HELLP syndrome may develop the hepatocyte failure, which may be associated with increased fetal and maternal mortality. They usually develop the jaundice, coagulopathy, low platelet, hypoglycemia, and for the treatment of acute fatty liver pregnancy and HELLP syndrome, the expeditious delivery of infant is recommended. And most of the cases is reversed once the delivery is occurred. If they fail to improve the liver function, then transplantation is again indicated. So coming toward the rare condition of the acute liver failure is acute ischemic hepatitis. Acute ischemic hepatitis is occur in case of the sudden cardiac arrest or in those in which the patient develop hypertension or hypovolemia. They may have the severe congestive heart failure. There are certain drugs can cause the hypotension or hypovolemia like niacin, cocaine, methamphetamine, and these patients usually have the transaminases level of 1000 to 2000 milligram per deciliter, and these patients need cardiovascular support as a treatment of choice. Liver transplant is not indicated. So here again you must know that these patients can develop the acute liver failure, but transplant is not indicated in this case. Another rare condition is the malignant infiltration. Malignant infiltration means acute severe hepatic infiltration can occur with the breast cancer. small cell lung cancer, lymphoma, myeloma, melanoma as well. So for diagnosis of this disease, you may obtain the images and the liver biopsy, and liver transplant again is not an option for these patients. Indeterminate etiology. So in spite of extensive initial evaluation, you fail to identify the etiology, then liver biopsy is mandatory in those cases where the acute liver failure is, but there is no existing cause of the acute liver failure. So these were the different causes of the acute liver failure. Coming toward the clinical manifestation, how these patients can present to you. So many of the initial symptoms in patients with acute liver failure are non-specific, like they can develop the fatigue, malaise, anorexia, nausea, vomiting, abdominal pain, and lethargy. As the liver failure progresses, patients who are initially anicteric may develop the jaundice, and those with the subtle mental status can change, become confused, or eventually comatose. So starting, they usually, before the development of the jaundice, they may have some these non-specific symptoms, like they may have the fatigue, malaise, anorexia, and later on they may have the altermentation as well. So what are the possible complications in the acute liver failure? Acute liver failure has caused the altermentation. So it basically involves the central nervous system, cause the hepatic encephalopathy, can cause the cerebral edema, seizure. Infection is the most common occur in the acute liver failure. They have the coagulopathy and bleeding, renal failure, hemodynamic collapse, and metabolic damage. So we will discuss about these complications one by one. What is diagnosis? How will you diagnose the acute liver failure? A good history is very important. Physical examination is second, and third, the investigation to know the etiology of the acute liver failure, the cause of the liver failure. Whenever you start taking history, you must know about the date of onset of jaundice and hepatoencephalopathy. As I told you, what is the importance of the date of onset of jaundice? You have to ask after how many days of jaundice patient develop the encephalopathy. If he develop within the 7 days, it means he has a hyperacute. If he develop the encephalopathy from 1 week to 4 weeks, it is acute. And if the patient is developed encephalopathy from 4 weeks to the 12th week of the jaundice, it means he or she may have the subacute. You may ask about the routine use of the alcohol or alcohol abuse, ask about the different use of the medication, prescription, and herbal and traditional medicine. You may ask about the family history. They might have Wilson disease or other members of the patients have Wilson disease or family history of Wilson disease. You may ask about the certain hepatic toxin like mushroom ingestion in recent past. And if you're suspecting the viral hepatitis related acute liver failure, you may ask about the exposure to the risk factor like travel history to the endemic areas and blood or blood related transfusion, any sexual contact, occupational history like those who are paramedic staff or those who are working in the dialysis center. They may have it at high risk. Ask about the piercing. Evidence of complication, you may ask about certain questions that may patient develop like renal failure, seizure, bleeding, or infection. This was the history. History is very important. What will you find on examination? You may have to see the mental status. And you may ask about certain question to see the conscious level of the patient. You have to check the flapping tremor. Flapping tremors are very important. If somebody has flapping tremor with jaundice, it means he or she may have the grade 1 hepatic encephalopathy. If the patient irritated, restless, agitated, grade 2 to 3, and if traumatized in grade 4. You may see rule out the stigmata of the chronic liver disease usually absent because in the definition of acute liver failure, somebody must not have the stigmata of chronic liver disease. You may see the sclera of the patient to see the jaundice and examination of abdomen. You will find the right upper quadrant tenderness, epidemic and if you are suspecting somebody has Budd-Chiari syndrome, then you may find the ascites in acute liver failure patients. And for clinical sign of elevated ICP, again very important. What investigation you really need for initially? Initially, you have to send the CBC to see the thrombocytopenia. LFTs, of course, you have to see the elevated level of the ALT. Electrolytes imbalance maybe the another issue of the acute liver failure. You may see the renal function test where the creatinine may be elevated. ABGs are again important, maybe in the hypoxemia and ammonia elevated level, arterial lactate often elevated. And if you are suspecting the viral hepatitis, you may check the hepatitis A, B, C, D, and E, and SMB, varicella zoster. For exclusion of Wilson disease, check the ceruloplasmin, serum urinary copper. For autoimmune, you may check the ANA, ASMA, immunoglobulin level. For Burkieri, need the hepatic Doppler. Drug and toxins, and the acetaminophen level. And for if, in spite of extensive workup, if the etiology is not clear, then you may think about the liver biopsy as if it is feasible, because liver biopsy usually is not feasible in case of acute liver failure due to the delayed coagulopathy. Management. How will you manage the patient? The most important, all the patient with acute liver failure should be start with the general support and then a specific therapy. Liver transplant is the ultimate treatment of the acute liver failure. Assessment and management representation. What will happen whenever you first time see your patient in the emergency? You have to exclude the cirrhosis, alcohol-induced liver injury, and malignant infiltration, because these three conditions are not required emergent liver transplant. You have to initially early discuss with the tertiary liver transplant center. Suppose you are working in a center where the transplant facility is not available and you are managing a patient with acute liver failure, you have to talk with the liver transplant team or transplant center about your patient, because your patient anytime may need liver transplant. You have to determine the etiology, guide the treatment, and determine the prognosis. Screen intensively for hepatic encephalopathy. Transfer to the specialized unit. If you are not working in a center where all facility like ICU and liver transplant facility is not available, and your patient has INR more than 1.5 and also hepatic encephalopathy and other poor prognostic factor, you have to decide immediately at the first visit. You have to decide what will you do. Either you will manage in your center, either you have to send your patient to the liver transplant center, or you may shift out to your patient to other center where all the facilities are available. So again, immediate measure. Determine the etiology, again important, because there are certain causes which need liver transplant. Here there are two boxes. One is the green box and the red box. The red box, when the cause of the acute liver failure doesn't need emergency of liver transplant, like hypoxic hepatitis, infiltrative diseases, primary liver cancer, alcoholic hepatitis doesn't need emergent liver transplant. But these are the green box need emergency liver transplant, like drug-induced acute liver failure, acute viral hepatitis, toxin-induced acute liver failure, Budd-Chiari syndrome, autoimmune, pregnancy-related, fulminant presentation of Wilson disease, autoimmune liver disease with the acute liver failure, acute Budd-Chiari syndrome, hepatitis B reactivation. All these need emergency liver transplant if they not respond initial treatment. So again, etiology with possible indication of liver disease. As I told you, acetaminophen poisoning is a life-threatening condition. You have to send toxicology screening and determine the paracetamol levels are necessary in every patient. If patient coming to you within the 4 hours, start the activated charcoal or give the activated charcoal. Then you have to start N-acetylcysteine, which is the antidote for patient with acetaminophen. In spite of all these things, if you are calculating things for its criteria and having the poor prognostic factor, then you may send your patient for liver transplant. This is again very important. The second most that we are facing, like viral hepatitis or autoimmune acute liver failure. Hepatitis B is the most common cause of the viral related acute liver failure. Hepatitis E is very rarely, or I haven't seen any case of the acute liver failure secondary to hepatitis A, but in this hepatitis A cause acute hepatitis. Hepatitis E in pregnancy can be a life-threatening condition and may develop the acute liver failure. If you are suspecting, then send the viral etiology, as I told you, send hepatitis B surface antigen, anti-HEV IgM, hepatitis B4 IgM. And if you are suspecting the autoimmune etiology, then you will take a liver biopsy and start corticosteroids for 7 days. But list for the emergency liver transplant if no improvement within the 7 days. Within the 7 days of steroid treatment, if your patient is not improving, then you may send your patient for the liver transplant. So etiology with possible indication, uncommon causes like Burkieri is an uncommon, Wilson disease is uncommon, health or acute fatty liver of pregnancy are uncommon causes, but uh, they may need the liver transplant. Consider for emergency liver transplant should not be delayed because these patients may not respond or they may need any time liver transplantation. Organ specific, as we all know that acute liver failure may cause the metabolic derangement, like cause the hypoglycemia, hyponatremia, hypophosphatemia, hypokalemia. So you have to correct this hypoglycemia, hyponatremia, hypokalemia, and also monitor all of them frequently. Acute liver failure can cause the infection, so need antibiotic. Acute liver failure also affect the coagulation. The prophylactic platelet or FFPs are not required. Acute liver failure cause hemodynamic instability, cause hypotension, may affect the lungs like acute respiratory distress syndrome, pulmonary overload, or pulmonary edema. Acute liver failure usually causes cerebral edema, cause cranial hypertension, and brain death as well. So how will you manage this organ specific related with acute liver failure? Somebody, as most patients presented with acute liver or severe acute liver injury, develop systemic vasodilatation with reduced effective center blood pressure. So these patients require crystalloid volume resuscitation, like normoxidine or ringalectide. They may need vasopressor agent like noradrenaline. When we're talking about the organ-specific management of the cardiovascular system, and what will happen, because acute liver failure can cause the acute adult respiratory distress syndrome, pulmonary edema. For this, they may need invasive airway management. They may need intubation and mechanical ventilation as well. So, what is the organ-specific management of GI-related guidance regarding nutrition needs in patient with acute liver is largely empirical. You must encourage your patient orally. Suppose your patient is developing hepatic encephalopathy, you may need the nasogastric tube for NG feeding, because calories are again very helpful for management of the acute liver failure. And as I told you that acute liver failure may cause the metabolic derangement, acute frequently associated with electrolytes and metabolic imbalance. You have to check the sugar level and electrolytes frequently and manage accordingly. You have to treat the acidosis and also to check the phosphate, magnesium, and may need the replacement as well. So what will happen when the acute liver failure uh, also cause 40 to 80% of the patient refer to liver unit with acute kidney injury, because these acute liver failure can also cause the acute kidney injury and associated with increased mortality and longer hospital stay. The risk of the kidney injury is increased when patients develop the acute liver failure with increased age, or those who have paracetamol induced acute liver failure, SIRS, hypotension or infection increase the risk of the acute kidney injury, and all these patients may need the hemodialysis. So this is the dialysis machine, and patient is here and need along with the acute liver failure, need to manage the acute kidney injury as well. And as I told you, acute liver failure is associated with the coagulopathy. And how will you manage and how will you monitor and manage? Because prophylactic correction of the coagulation of platelet level is necessary if you are prophylactically giving the platelet, because thrombocytopenia is a common feature of the acute liver failure that may instantly adversely affect the prognosis, may increase the risk of thrombosis or transfusion-related acute lung injury. So avoid the prophylactic use of the platelet, but fresh frozen plasma can be given in the limited specific situation like insertion of the ICP monitor or acute bleeding. Suppose your patient is actively bleeding, then you may arrange the fresh frozen plasma, you may transfuse the platelet, or if you are doing some invasive procedure like ICP monitoring, it is intracranial pressure monitoring, monitoring if you need it. And your target of the hemoglobin should be more than 7, not more than 7, just up to the 7. If your patient's blood is less than 7, then you may transfuse and as what will happen, as I told you, the acute hepatic failure worse with the infection may lead to the sepsis, inflammation, and the anti-inflammatory management is required. Patient with acute liver failure increased risk of developing infection, sepsis, septic shock. So severe untreated infection may preclude the liver transplant and complicate the post-operation. So it is very important to give the antibiotic to the patient with acute liver failure, because if you are not giving the antibiotic and your patient needs the liver transplant, then preclude liver transplant and complications will increase after the liver transplant. So you have to give early anti-infection treatment should be introduced. But prophylactical antifungal antiviral is not recommended. So what will happen? The brain in acute liver failure, hepatic encephalopathy. Hepatic encephalopathy tend to fluctuate, may progress from the lack of the awareness to the deep coma. As I told you, there are 4 grades of the hepatic encephalopathy. Grade 1, where the flapping tremor can be seen. In grade 2 and 3, the irritation, agitation, and grade 4 is the coma. So how will you manage the hepatic encephalopathy? In early stage of the hepatic encephalopathy, lactulose may be used either orally or rectally to purge bowel purge, but it should not be administered to the point of diarrhea, because according to some experts, that it may interfere with the surgical field by increasing bowel distension during the liver transplant. So the lactulose is a good choice for the early stage of the hepatic encephalopathy, because hepatic encephalopathy, these patients may develop the seizure activity. It should be treated with the phenytoin and benzodiazepine with the short half-life. Prophylactic phenytoin is not recommended at all. Brain in acute liver failure, hepatic encephalopathy. In the event of intracranial hypertension, the mannitol at the dose of 0.5 to 1 mg per kg body weight is first line therapy. However, prophylactic administration of mannitol is not recommended. So treatment of the liver failure, the definite treatment of the liver failure. The before this, I was talked about the specific different etiology, and according to their etiology, you can give the specific antidote. You may give antibiotic in the mushroom poisoning. You may give the N-acetylcysteine in poisoning. In viral hepatitis, you may give nucleotide, acyclovir. But the definite treatment of the acute liver failure is the liver transplant. So what is liver transplant? Liver transplant, urgent hepatic transplant, is indicated in acute liver failure where prognostic indicator there is a high likelihood of death. How will you do this? This is a procedure where the healthy portion of donor liver is removed and can be transferred or transplanted to the recipient who has a diseased liver. So this is a life-saving procedure, and another choice is the living donor or auxiliary liver transplant may be considered in settings of limited organ supply, but it usually remains controversial. It has been seen that 1 year survival following emergency liver transplant for acute liver failure is around 80%. So selection of liver transplant depends on the accurate prediction of the survival without transplant, consideration of survival potential after liver transplant, consideration of whether a patient is too sick to transplant. So on what basis you will send your patient for the liver transplant, or on what basis the liver transplant team will decide to do the emergency liver transplant? There is the criteria which is known as the King's College criteria. King's College criteria has two different classes, two different components. One is for the paracetamol induced acute liver failure, and second in other than the paracetamol, like viral hepatitis related, Wilson disease related, Budd-Chiari related, or other causes other than the paracetamol. So in case of the paracetamol, they usually uh, check the arterial pH, which should be less than 3.7 after resuscitation or more than 24 hours since ingestion. Lactate more than 3 millimole per liter or following criteria like patient have hepatic encephalopathy grade 3 or serum creatinine more than 300 micromole per liter or not more than 6.5. So if somebody with paracetamol poisoning having these criteria may need emergency liver transplant. If somebody doesn't ingested the paracetamol but have a suspicious of mushroom poisoning, viral hepatitis related acute liver failure, Budd-Chiari syndrome, or autoimmune related hepatitis or Wilson disease, other than the paracetamol, if they have the INR more than 6.5 or 3 out of following criteria, either etiology is indeterminate, hepatitis or drug induced, age less than 10 years or more than 40 years, interval jaundice and encephalopathy more than 7 days, bilirubin more than 300 micromoles per liter, and INR more than 3.5, then they need urgent liver transplant. So, so here we discussed about the definite treatment of the liver transplant. What will happen when the transplant center is away from your town and the patient don't have the donor? So for their temporary survival, they need the bioartificial liver. I will tell you about this is like a dialysis machine, which is temporary fix and keep the patient alive until the transplant is available. This is not widely available. Even I didn't see yet in the Pakistan this machine. At least we don't have in our hospital. So it was all about the acute liver failure. So guys, we discussed about the definition of acute liver failure. I hope that you have better understand that what will happen if somebody doesn't have previously existing liver disease but develop the jaundice and coagulopathy and then hepatic encephalopathy. Then I discussed about the subclassification, acute liver failure subclassified into the hyperacute, acute, and subacute. And we talk about the disease burden. I told you that in Pakistan and in subcontinent we have the viral hepatitis related acute liver failure common as compared to the US and UK, where the paracetamol poisoning is the common cause of the acute liver failure. We discussed different etiology in detail, and then we discussed the general management of the acute liver failure according to their etiology. We discussed the organ specific management because acute liver failure usually affect the metabolism and affect the brain, kidney, lung. Whenever it involve, whenever it affect the kidney dialysis. When it affect the lung, it needs mechanical ventilation, intubation, mechanical ventilation. Whenever it affect the brain, it need hepatic encephalopathy management like lactulose or mannitol can be given in case of the cerebral edema, and this condition may lead to the infection, so need antibiotic. And we talk about the liver transplant. I told you about liver transplant is the definite treatment of the acute liver failure and the life saving. Whenever emergency liver transplant is done, the survival rate is quite good. 1 year survival is 80%. So 1 year survival is 80%. It's quite good. So it is all about the acute liver failure. So I think it is. We have only 4 minutes to end up this class. So I discuss all the necessary aspects of the acute liver failure. And if uh, if you any query, you may ask about on chat. This where this you can ask me on the chatting area. Anybody want to ask anything regarding the acute liver failure? You may type on the getting it. फुरकान,
यस सर।
हाँ फुरकान, कोई पूछना चाह रहा है, कोई कोई चीज कोई चैट में है?
सर अभी तक तो किसी का कोई क्वेश्चन नहीं है।
ओके, अगर कोई क्वेश्चन करना चाहे तो हमारे पास है, कोई 3-4 मिनट है, ठीक है।
स्टूडेंट्स अगर आप लोगों की कोई क्वेश्चन है तो काइंडली आप लोग आप अपने आप को अनम्यूट कर सकते हैं, अनम्यूट करके क्वेश्चन कर लीजिए अगर आप करना चाह रहे हैं।
यार सारे टैलेंटेड लोग हैं यार ऐसा।
Sir, what is a flapping tremor?
What?
Flapping tremor.
Flapping tremor basically, flapping tremor just like when you give the command to your patient, you may say your patient to straight hand and show your palms, and if the patient is unable to hold the palms in a proper way, so it means flapping means just like जैसे वो परिंदे नहीं होते, उनके पर जो हिल रहे होते हैं, just like flapping. This is the grade 1 hepatic encephalopathy. This is a sort of, just you can say that on clinical examination you can say that the patient has a grade 1 hepatic encephalopathy. As I told you, for in the part of the examination of the acute liver failure, you must first see the flapping tremor. So this is about it.